Thank you for that wonderful introduction. And these are my disclaimers for today's talk. We are all familiar with fluorescein angiography and OCT, and we discussed a little bit about these techniques before. But where does OCTA fit in? OCTA, or OCT angiography, displays the vessels of the retina and really vague profiles of the choroid without a contrasting agent, which is currently, in the current climate, is extremely important both for the patient and for us to be able to keep looking after our most vulnerable patients. So OCT angiography works in a way that there is a light of a single wavelength that's directed towards the retina, and the change in the signal is measured in the emergent light between sequential B scans taken at the same location at very high resolution of the passing blood cells in the different vessels. Therefore, it is processed to construct a map of blood flow, and it shows the vascular structures where there is blood flow through the vessels, and it's fixed in a point in time, as it can see in these images below. The flow is, if the flow is extremely slow on one of the vessels, then there is no signal on OCTA. And it's the same if the flow is extremely fast beyond what we can record. So the flow within the acquisition range will come from the decorrelation of signal on OCTA, and you will see a lot of these little red dots when you look at your OCTA images. These very much help you to be able to decipher where the vessels might be. So it's very important that you actually think about the relevant question that you need to ask, because otherwise you will not be able to appreciate the answer that the images are giving you. So how do we work it in clinic? We tend to take a standard OCT image, including the volume scan, then a macular-centered OCTA, and you can decide which size do you want to take. If you have a very small abnormality, you might take the 3x3. A larger abnormality that where you really need to see the whole of the macular area, you will probably need to take the 8x8. And if you want to go further out towards the periphery, then you can add additional fields, especially if the pathology is eccentric to the macula. And you end up with a beautiful 12x12 image where you can see the vessels outside of the arcade, the whole of the optic disc, and a little bit to the nasal side of the disc as well. So when you're looking at OCTA images, it is crucial that you understand the retinal anatomy. And we sometimes have to go back real basics to be able to decode the message that OCTA is giving us. We need to look at the entire retina. We need to examine how the color depth and coded maps gives us the information about flow and the vessels. And then we go from the inner limiting membrane all the way down to the choroid and look at the retina in all layers, including the RP and the Brooks complex. It's very much recommended that you always look at the Anvers lab that's displayed simultaneously, so you know where you are on the image. And if we go from the full retina, that is on the left-hand side, beautifully color-coded, and then you can see that through the superficial and the deep retina, the vascular area, down to the choroid, you are able to see all the vessels that have relevant amount of flow in them. And you can also see on the OCT as to which depth you are, so you are able to orient yourself in the images. So taking all of these issues in hand, we will be able to see how we use it in patients, such as this patient with diabetic retinopathy. So this patient was referred with a macular edema in the right eye and previously had bilateral factor emulsification and intraocular lens implantation 3 months previously. It says 5 years history of type 2 diabetes mellitus and has very good vision with 81 and 80 letters on a 6-meter chart. And if you look at the images, the color images that are montaged, then you will see that there are hemorrhages and also some microaneurysms in both eyes. When we look at the OCTA images of the right eye, then we are able to see the small vessels around the foveolar vascular zone. And you can also see at the same time on the OCT slab where you are in the retina. So you're able to decide which plexus you're looking at. So when you look at the right eye skeletonized vessel map on panel A and the perfusion scan on panel B, you can see that on both you very much appreciate that the foveolar vascular zone is elongated and it's not a very nice circular shape. So while there are some changes in the foveolar vascular zone, however, the vessels around the foveolar vascular zone seem fairly perfused, and there is no obvious capillary non-perfusion in the vicinity of the fovea. That probably explains the good vision the patient has currently. And if you look at the different matrix, then you will be able to see that the vessels and also the perfusion map, you see that there is good perfusion around the foveal vascular zone. When we go to the left eye, then you will see that on the superficial retinal slab and the corresponding OCTA image, there is reduced capillary density in the parafoveal area. And there is also pruning of the vessels. So the vessels seem to sort of stop at a given point without being connected to any other vessels. But on this image, there is no cyst, and that's the eye that was not operated on some time ago with cataract surgery. So even on the left eye, you can see that the vascular zone, foveolar vascular zone, is larger than what you would expect, and it's very irregularly shaped. And in this eye, you can actually see some capillary non-perfusion, but it's for the uninitiated, or if you don't look at it very carefully, you might miss it. And some of these areas we will look at in a minute, much in more detail. But when you get the perfusion map, the blood vessel map, and the perfusion map, you will see that there is a fair bit of capillary non-perfusion, these areas in blue. So based on these studies, we actually went ahead and did fluorescein angiography as well. And you can see that in the right eye, there is some patholoid changes and there are some microaneurysms, while in the left eye, there is a much larger foveolar vascular zone. And those areas that were blue on the OCTA, you can see that there is very little. So there is very little circulation on the fluorescein, and also that you can see some vessels that are coursing through an ischemic area, and you can see a hot disc. So all of these together mean that this patient is already in the middle of having some vascular problems with his diabetes, and we instituted high frequency monitoring for this patient, and because it suggested that the retinopathy might worsen further. So when we think about capillary non-perfusion, it's always very difficult to ask for fluorescein angiography, and we're simply not at the point, even in the COVID era at the moment, that we could be doing as many fluorescein angiograms as we would like to do. So I would like to appreciate this thought on this next case. So this is one of our patients who is just about to retire and had type 2 diabetes for 10 years. And you can appreciate new vessels on the disc. And you can see that it's had a reasonable coverage with PRP laser. And despite that, there are still some new vessels on the disc. Is also on anti-VEGF therapy for diabetic macular edema. And you can see that there are still some cysts in the retina, but overall the retinal contour is relatively normal. So when we look at the left eye, though, this patient has been asked to come back several times to have the left eye monitored, and in the temporal area of the OCT, you can see that there are some suspicious vessels, and it has always been described as a questionable ERMA, and on the surface of an ERM. So, but the patient's vision was sort of slowly going downhill, and that's why we decided that we will do an OCTA. When you do the OCTA in the left eye, in the area that was in question, then you can see that there is a huge area of neovascularization. This front is very obvious on OCTA. It was nowhere near as obvious on the previous images on the OCT. But in the OCTA, you can see it very well. And now that you appreciate where it is, you can also see it on the color image. So the OCTA helped you to decipher where the new vessels are without the use of fluorescein. And you can see that it is developing, the new vessel complex is developing at the edge of the normal and the ischemic retina, the normal and the ischemic retina, and that these new vessels look active, and therefore this patient requires treatment with fine retinal photocoagulation, or sometimes with anti-VEGF, whichever your treatment regime might allow you to do in the current era. So we did do the PRP, and you can see it on the fluorescein that we were completely right. The whole neovascularization is surrounded by ischemic area, just as you would see on the OCTA, large areas of ischemia in the periphery. And these ischemic areas, you can always see that the vessels, when they go through, they seem to stain, or sort of like this, they would have a minimal leakage. It doesn't necessarily mean that this whole area is new vessels, but the leakage comes from the sheer fact that they're going through the ischemic area. And unfortunately, this patient passed away in a myocardial infarct not long after the start of anti-VEGF treatment and the finishing of the PRP, pretty much confirming that he was a vascular path right from the beginning. So the next case will show us that it doesn't always have to be ischemia that causes the vessels to be leaky or staining a little bit. This is a 48-year-old man with an 8-week history of mild blurring of the vision. There is really not much of a cardiovascular history, and the vision is still very good compared to the fact as to how the eye looks, with 4-quadrant hemorrhages, dilated tortuous veins, and what you would describe as a potential central retinal vein occlusion with lots of hemorrhages. So the fluorescein angiography shows that there's a relatively good perfusion. And when we do the OCTA, then you can see that that there is severe macular edema shown on the OCT image itself. So you would have to think about how we are going to segment this image, because sometimes when you have this much edema, then you really struggle to find the right layer in the retina, and you really have to think about resegmenting or changing the lines to make sure that you get the correct segmentation of the slab that you want to see. So the adjustment of the segmentation lines is usually quite easily performed by just moving the segmentation line and making sure that you are in the layer where you would like to be, and you segmented the layer you wanted to have. And then you can see that in this case, the foveolar vascular zone is normal looking. And you see on the unfast lab that there are a number of cysts in this eye. But the actual retinal vasculature looks very good, and that adds up with the amount of vision, the very good vision that this patient has. So just to finish off, I would like to just present this very last case that will be able to show us that that it's very important that we look at the OCT, the patient, and all the images together. So this patient is a 75-year-old female with 1 year of blurred vision. And she also has vascular problems, as you might have imagined, and the history of treated hypertension and angina. And the right eye has poorer vision, but the left eye has very good vision. And in the right eye, there are a few dot hemorrhages, as you can see on this. And the RCT of that eye showed sort of a nondescript generalized edema in the right eye. And we weren't quite sure what the origin of this could have been. You can also see quite marked epiretinal membrane. The left eye had a normal OCT. So when we looked at the OCTA of this patient at the relevant area, then you see that there are large areas of capillary non-perfusion and all over in this lab. And you also see the areas of spatuloid cysts in the right eye. And wherever you look at, you see quite a number of areas of ischemia. These areas are very central, and they explain partly as to why the vision is so poor, together with some of the outer retinal changes seen on the OCT itself. So when we commencing anti-VEGF treatment, the edema resolved, however, the vision increased to nearly normal, but not quite normal. The capillaries are better visible. It's always up for a debate, as you know, if they do come back or just visualize better. But you can see that the areas of ischemia still remained relatively stable in terms of their size and location. So what have we learned from these cases? So when you're using just color imaging and spectral domain OCT, high throughput imaging clinics can miss key signs of ischemia and even proliferative diabetic retinopathy if they're only using those imaging modalities. Sometimes the severity of the capillary closure is not appreciated on color imaging, as a lot of patients at that stage have a featureless retina. So instead of seeing lots of abnormalities, you see like grayish featureless retina. And they can have very severe capillary non-perfusion, but not very many overt signs of the disease. Sometimes you as the OCTs, you might see retinal thinning, but again, the severity of the ischemia might be missed. So OCTA helps to detect ischemia and retinal new vessels with high fidelity, especially if you think about your imaging protocol and make sure that you ask for the questionable area to be imaged. At the moment, we don't really understand absolutely everything about OCTA, but with the COVID, we also found that we wanting to keep the patients in clinic for a shorter period of time, not wanting to do as many fluoresceins as we might have done otherwise, and with the patients appreciating that they don't have to have fluorescein angiography, we are doing more and more of this technique, and of course, we are learning more and more about it. Thank you very much for your attention.